Good morning, everyone. This is Mike Toso. I'm a program officer with Johns Hopkins Center for Communication Programs. This is the third in our series of malaria social and behavior change communication evidence-based discussions. Before we begin, I'd like to introduce our moderator, Bridget Higginbotham.
Thank you, Mike. Good morning, good afternoon, and good evening, everyone. Can you hear me?
Yep.
Okay.
Just as a word of quick introduction, Bridget is a malaria advisor for the U.S. President's Malaria Initiative. As a member of the Social Behavior Change team, she provides support to PMI programs in Niger and Guinea. Bridget is going to start us off today with a few words about how this activity fits in within PMI's global strategy. Welcome, Bridget.
Thank you, Mike. And again, hello to everyone. As Mike said, the U.S. President's Malaria Initiative is supporting this activity. So thank you for this opportunity to say a word or two about how it fits into our global strategy. So PMI prioritizes activities that improve countries' capacity to collect and use information. And oftentimes this is in our own countries, but when appropriate, we can look at other countries' data and studies and apply it to our own. We're also very interested in building the capacity of health systems of countries where we work. And so from our perspective, regular discussion about rigorous malaria SBCC evidence helps to build and maintain capacity among the malaria community. So we hope this activity meets your needs. And thank you to Breakthrough Action and to Dr. Chandler.
Thank you so much, Bridget. Just a few words about today. This discussion will be recorded. We will be sharing the slides and the webinar recording after the discussion. During the discussion, you'll be on mute, but please keep your questions and add them in the chat box to the side. When it comes to the discussion time, we will open up the floor. You will be able to either speak or type your question into the chat box. If you'd like to speak, there's a little button on the black bar of your computer. You can raise your hand and we will call on you. As usual, these discussions are structured like a research paper. If you are following along in the discussion guide, the blue slides will indicate which section addresses specific questions in that guide. In addition to learning about Dr. Chandler's findings, we hope today's discussion shed lights on tips for reading and interpreting malaria SBCC research for your own work. Today's article comes from an online searchable database for malaria SBCC evidence, which includes both peer-reviewed articles and gray literature. Please take time to explore it when you have a chance. I'd like to introduce our presenter, Professor Clare Chandler. Dr. Chandler is the Director of Interdisciplinary Antimicrobial Research Center at the London School of Hygiene and Tropical Medicine. She's a professor in medical anthropology and currently heads the Anthropology of Antimicrobial Resistance Research Group, the largest of its kind globally. She's a leading medical anthropologist on the topic of medicines and healthcare. Her research has produced rich and policy-relevant accounts of the roles of medicines and of diagnostic tests across settings with different resource availability. Her in-depth ethnographic field sites have been in Uganda and in Tanzania. She's also led research in Ghana, Nigeria, Cameroon, Sierra Leone, Malawi, Zimbabwe, Ethiopia, South Africa, Afghanistan, India, Cambodia, Vietnam, the Philippines, Thailand, and Myanmar, as well as the United Kingdom. Her methodological expertise are in ethnography, mixed method studies, intervention design, and the evaluation of complex health interventions. She also has a keen interest in capacity development in low resource settings, both in practice and as a research topic. She has provided technical advice to the government of the United Kingdom, the World Health Organization, and many lower and middle income governments. Welcome, Dr. Chandler.
Thank you very much.
Before we get started with diving into the research today, we'd like to frame our discussion around the social-ecological model, which we find a helpful way to think about who and what influences important decision-making about behaviors. The evidence base that we have just mentioned describes a growing body of research, findings that tell us behavior isn't the result of simply exchanging of information with an individual. People make decisions based on a number of individual social and structural influences. A recurring theme in this evidence discussion series will be a focus on interventions designed to influence multiple audiences and structures within this model. When we say the socio-ecological model influences our work, we are acknowledging that working on individual, social, and structural levels must be addressed to achieve positive behaviors and health outcomes. We've populated the slide with a few examples of the factors at the individual, interpersonal, community, and societal levels that the study we're going to discuss today has taken into account. I will now pass the floor to our presenter for the day, Dr. Clare Chandler, who's going to take us through her research. The floor is yours, Dr. Chandler.
Thank you very much, Mike, and thank you for inviting me to talk about this research, and hello to everybody. Let me begin with a brief description of what we just set out to do with this project. If you're following the discussion guide, this is where we answer the first question in the discussion guide: what evidence did authors collect and use to come to the conclusion that these approaches might be effective? So our objectives, so we had a set of objectives of what we wanted to achieve before we set out the intervention design, and the goal was to improve prescribers' adherence to malaria diagnostic tests. And that means we wanted them to reduce the amount of anti-malarials that were being prescribed. We already knew that there was a lot of non-adherence to diagnostic testing, both in microscopy and rapid diagnostic tests. And at baseline, when we started out these studies, we had about 50% of people who had a negative test were still being given an anti-malarial. So we really wanted to reduce that and improve appropriate treatment. So that was the goal of the study. So we carried this study out in Tanzania. We also, at the same time, were doing a number of studies in other countries through the ACT consortium that carried out with similar methods. This project in Tanzania was carried out in 2 different regions that had different levels of malaria. So in Moshi, the level of malaria had actually decreased quite a lot in the previous few years. And so it was actually quite a low level of malaria, whereas in Maheza district, we had a slightly higher level of malaria. So we were able to compare this approach across those different areas. We know that prescribing behavior from our descriptive work, we already knew that there was going to be a difference in how people would respond to diagnostic tests in low transmission areas. And the trust in the test might be different in those areas compared to settings where the test was positive more often. So to do the project, we wanted to include these 2 different sites, but because they had different baseline malaria endemicity, we wanted to make sure that we powered the study to be able to evaluate our interventions in each of these sites. So we randomly selected health facilities so these were dispensary level. That means it's primary care, so not in hospitals. So these primary health care facilities, government facilities in each of the areas. We picked 18 facilities in each area at random from those that were eligible, and then we allocated 3 study arms to each of these to these 18 facilities. So we randomly allocated them to either be in the control, the health worker arm, or the health worker and patient arm. So we had 3 different approaches. We had 12 facilities overall, 6 in each site, that received the standard RDT training. So the government of Tanzania had introduced a standard training program of 2 days for health workers, which was actually quite a good and comprehensive program. We then expanded upon that. We delivered that training program in the control arm. In the second arm, we expanded upon that to include some additional workshops and some additional materials. And then in the third arm, in addition to that, we added a patient-centred section, which was actually the delivery of a leaflet and poster. So the timeline looks like this. We started with doing formative research, and I had actually done 2 years of ethnographic fieldwork on this topic in these areas prior to starting this project. So that was anthropological fieldwork, working with healthcare providers and patients. And then we did some formative research specifically in the primary healthcare settings to try and understand current practices now that RDTs have been started to be introduced. And we then were trying to identify areas in which we could make some relatively low cost amendments that might change the behaviour of healthcare workers, remembering that from our baseline, people were completely ignoring the rapid diagnostic tests. By the time we did our baseline here around the formative research, actually diagnostic testing had been introduced for a bit longer nationally, and we had already seen some reduction or increase in adherence to diagnostic testing. So actually it wasn't as bad as when we started off in our initial work in about 2006. We had about 50% of people getting antimalarials when they had a negative test, and it had already reduced down quite a lot at our baseline. So that was already a good starting place. But what we did to try and design the study was to review the evidence of other interventions that had worked in similar kinds of settings to reduce or to improve health worker prescribing. And we looked at the various different theories about theories of change that might apply to health workers. And we tried to find some theories that actually seemed to fit best with our health workers who we were working with, and the communities of practice ideas from Etienne Wenger seemed to have the most salience. So we kind of built on that for these small-scale workshops, which combined with evidence from other settings, particularly high-income settings where small peer groups seem to have been effective in changing behaviour. And then we did a substantial set of pre-testing and piloting, and particularly of the patient information leaflet. We spent a lot of time piloting that, and also developing and piloting these training materials, which we did with various professional organisations who helped us to develop those. We then delivered the intervention, and we had an end-line survey where we compared prescribing practices across the different healthcare facilities. So the things that we found in the formative research were really that health workers prescribe, exactly as Mike was saying in the introduction, their prescribing behaviour is not just something that is in their head. What's in their head is something that is informed by a wider set of communities of practice, that the reason that they're prescribing in the way they do is because other people do, because they fear doing the wrong thing, they fear the consequences of not giving an antimalarial in the case of a severely sick patient or a potentially severely sick patient who may not come back. So they had really good reasons that they wanted to prescribe an antimalarial, and also that patients expected antimalarial. So we realised we were going to have to shift these expectations and shift what people thought was expected of them amongst their peers. So we did this through a series of steps. Our idea was that people would be taken through, the health workers would be taken through these different steps of recognising why we should be changing practice in terms of the changing epidemiology of malaria reducing in these particular areas, that actually not all fevers are due to malaria, that we need to shift from what we used to say about treat everybody with an anti-malaria. We needed to shift those narratives. And then we wanted to give people the opportunity to practice and come back. So they were given kind of homework, go away and practice in in your clinic, and come back with the actual challenges you have so that we can discuss them in these workshops. So our workshops operated over a period of time where people would be brought back together with other peers in a facilitated workshop where they could talk about what they'd done in practice. So then they're incorporating the RDT into their practice, talking about the challenges they face, and then trying out new ways of trying to keep it into, to incorporate it into what they were doing in everyday practice. And so we were trying to then help them to adhere to the results through this kind of process of recognizing that their entire community of practice was changing. And we tried to change the community of practice as well through the patients and this patient-oriented leaflet. So methods, how did we evaluate what we did? If you are following the discussion guide, this is in answer to questions 5 and 6, where we explore the study design and analysis. And so in order to establish causality of the intervention, rather than just having a before and after study, which can be subject to other factors that may have changed over time, which we did see. We knew already there was an increasing adherence to RDTs kind of going on in the background, as it were. We therefore did a randomized controlled trial studies, and it was clustered so that we would have everybody in a particular clinic would be clustered, allocated to the same intervention, rather than having different individuals within the same clinic being asked to do different things. The idea was that they would work as a group. So that's different to some of the other studies that you might see around individual clinicians, individually randomized patients or individually randomized clinicians. So it was a cluster randomized trial, and we administered a patient exit survey to establish our outcome. And we attempted to control for variations between facilities. Of course, you have some that are larger than others and some that have different characteristics, by stratifying the facilities and ensuring that we had similar numbers across our, each of the facilities, each of the arms. And then we created a score, which is called a risk difference, where we said what's the cluster level, what's the average for each health facility, and then what's the difference between the control and the average of the health facilities, the average between each of the health facilities in each arm. And so for the results, if you're following the discussion guide, the next few slides answer questions 2, 3, and 4 about behaviour and communication objectives, as well as how the impact was measured. So here, I'm going to take you through our findings to kind of, in the chronological order, I think it makes most sense. So our primary outcome, I will show it kind of towards the end of these slides. So the first thing is, did people use the RDT at all? So amongst those who are eligible for testing, so that's people who are presenting with a febrile illness, did a clinician do an RDT? And what we can see is in the control arm, 55% of eligible patients were tested. And it was the same in the health worker arm, but it was higher, statistically significantly higher in the health worker and patient arm. And that's in the arm where we had given the health worker leaflets to talk to the patient about. And we've done a lot of work with community members in deciding what the messages should be. We tested those messages. We tested whether people could read, if they were paired up with somebody who was more literate, what did they understand by the messages in this leaflet? And it's quite interesting to see just that leaflet on its own can have such a big impact, because it's relatively low cost intervention in the end. So that really increased the number of patients, febrile patients, who were tested. And then if you look at adherence, amongst those who were tested, you can see how many were RDT negative who didn't receive an antimalarial. And actually, the majority across all of these did not did not receive an antimalarial. So that's much, much better than it was when we were working on this back in 2006 when RDTs were just being introduced. So we can see here that across all arms it was much better, but it's an incremental increase across our 3 study arms. So you've got 19% receiving an antimalarial when the guidelines would say they shouldn't do in the control arm, and that being reduced quite dramatically down to 6% in the health worker arm, and then reduced again to 4% in the health worker and patient arm. So you can see the intervention having a positive impact, even though the starting point is already quite a lot lower than it was when we initially started this work. And then if you combine those results together, we get this is our primary outcome, the treatment of eligible patients who had a non-malarial illness. So amongst those patients who had a fever, who were tested. So first of all, how many of them were malaria negative? Most of them were negative. And then amongst those who were negative, you can see how many of them were prescribed incorrectly. So actually it's a very small number across all of them, but it is statistically significantly smaller in the intervention, in both of the intervention arms. You'll notice that there are more malaria negatives in the health worker and patient arm, and I wonder if that's because they tested more patients in that arm, and maybe the patients that they were testing were actually negative. So then maybe the clinical judgment was correct in terms of not testing some of the other patients. I don't know. We wouldn't know that from the data that we have. But yeah, you can see that there is a statistically significant difference. And I suppose 8% down to 2%, when you scale that up, is quite a large number of patients at least. But then one of the consequences that we've been looking at, and we've found this from across our studies, we published a paper across 9 of our study sites and 9 of our study countries, where we found the same thing, that prescribing of antimalarials went down with RDTs, but antibiotics went up, and we can see the same here. So the prescribing of antibiotics is higher here than it was at baseline. It was between 55 and 60, I think, at baseline, and so it actually increased as a result of the introduction of rapid diagnostic tests, and so this behaviour, I think, needing to prescribe some kind of medicine is a really important phenomenon in the pharmaceuticalization of care that requires further work. And so here, the key results in terms of the quality of the RDT reporting, this was looking at the records that the physicians were, or the clinical officers mainly, were writing in the notes. They write a record for every patient, and actually we found that those records were pretty good because we compared those with our patient exit interviews. So the patient recall and the register were pretty much giving the same results. So that's reassuring in terms of our subsample of patients that we interviewed on exit. So what are the programmatic implications? Now we've reviewed the results. What does it all mean, and how does that help us? In the next slides, we'll explain discussion guide question 7, which asks about generalizability. So one of the questions is, does an 8 to 2% change matter? I think that's something that we might want to consider in terms of cost effectiveness. Do you want to implement this intervention to reduce it down even further? I think one of the things that we often fail to think about when we're considering cost effectiveness is that we think that we have to continue this intervention forever. But my suspicion, having worked on a number of these interventions in different settings, is once you've done it, you don't have to keep doing it. Some interventions, like hand washing interventions, you have to keep doing. But once you've changed this kind of expectation about the level of malaria you're likely to see in your clinical practice, I don't think you will need to continue to do this kind of more expensive intervention. I think it's more like a one-off intervention that has to happen to kind of retrain the mindset, that then I think once you've got mentors continuing to mentor their clinical officers coming through and the nurses coming through, then I think that you probably don't have to continue to do that kind of more intensive intervention. So I think in this kind of scenario, it's probably a one-off. And I think probably once you scale up, then an 8% down to 2% change probably does matter. And actually, if you look at the proportion of anti-malarials that were given to patients who had a malaria negative, I'd say 19% down to 6% and 4% is quite an important difference, because presumably those patients should then be assessed for other causes of illness. And then one of the points that I think is really important is that the patient intervention that we implemented was really, really cheap. It took quite a lot to make. It was quite an intensive development process. But then in terms of scalable, I think it is very cheap to just print out these pages, and I think it helps the communication between the health worker and the patient. Obviously, these were setting-specific drawings, so it wouldn't necessarily travel to a different setting. I don't know what it would do if you just had that and you didn't have the health worker training. That would be an interesting question to answer, and probably worthwhile doing given how cheap the intervention was. And so what's the main implication? That the prescriber interventions employed in the study show that the combination of a simple and repeatable behavioural intervention can reduce overdiagnosis of malaria to close to zero in an area where the majority of antimalarials have been prescribed previously to those who didn't have parasites. And because fever is still the most common diagnosis in clinics in sub-Saharan Africa, even modest reductions in overdiagnosis could have a significant impact on reducing antimalarial use. But there is this big question of what to do with RDT negative patients and the question of increasing antibiotic use. So this is by no means everything is over scenario. It kind of has raised a number of other issues that still need to be studied. And it's possible that the additional benefit of the intervention arms can be attributed to the emphasis on changing practice through a shared experience of the process of change. The strengths of the study, I think one of the strongest things about the design of the interventions was the extensive qualitative research that was conducted before the study. And then we have done an interesting qualitative evaluation, which we haven't talked about today, about what the implications were following the study. So how the health workers ended up changing. One of the things was that one of the unintended consequences of asking the health workers to change their practice in this way was that they changed and became more aligned to the overall goals of the program and felt that they were less aligned to the patient. They were less able to provide care to the specific patient because they were being told, and they felt that they had a kind of somebody on their shoulder watching them because they were receiving text messages and so on. And so they felt that they had to align with the program and were saying things like, oh, well, does this patient really deserve an antimalarial? Which I think is the kind of language that gives away that people were starting to line up as gatekeepers to medicines. And I think that's a question that needs to be taken forward and taken quite seriously. The control and intervention group comparison, I think, is really important. We always say that randomized control trials provide us the best quality of evidence, but that it wasn't a blinded randomized control trial. We don't know that, and we don't know that simply being involved in an intervention full stop may have motivated people to change their practices. It may not be the intervention itself, it may just be the way that they were engaged with it that could have changed their practice. That's always a possibility. And limitations, so that's what I'm saying about the incentivization. And then the post-intervention survey, so we haven't described the change between 2 points in time, although we do have this baseline survey. So we have an idea of what people were doing at baseline. It wasn't, the study design didn't incorporate change from baseline to end line in addition to comparison between arms. That's fairly standard in a in a randomized controlled trial theory, that is the best practice currently of how to evaluate causality. Lessons learned. So changing prescribing practice is possible. If we use peer groups, physical activities, we had people kind of walking around and doing songs and various different things as part of the workshop. Self-observation and feedback, direct clinician text. All of our materials are available on the ACT Consortium website. You can download our manuals that we used. Everything is open access and is free to use, translate, adapt, adopt. But there are these questions about how clinician accountability might shift away from patients, and what does that mean? And strict adherence to RDT results might lead to prescription of other pharmaceuticals. And actually, one of the other unintended consequences we have found in a paper that's just about to be published is that we actually, in many of our settings where we've reduced prescribing for with RDT negatives, we've also reduced antimalarial prescribing in RDT positives. So we're actually reducing appropriate use in positives. So RDTs certainly are not sufficient on their own to improve clinical care. There are longer term things we need to do about improving health worker abilities to care and diagnose patients. So I think we've reached the end where we have a discussion, a Q&A with participants. Is that who monitors that bit?
Thank you so much, Dr. Chandler. We appreciate your walking us through your research. At this point, if anyone has any questions, you may either raise your hand in the participant box and we'll call on you. Otherwise, you can add them to the chat box. Maybe while we're letting people think things over a little bit, Claire, I can start with one question. You had said something about the cost of this intervention sort of almost being a sunk cost. It's maybe a one and done. It's the adoption of a behavior, whereas later on, once they've learned it, maybe they'll maintain that behavior. It seems like a really interesting thing, I think, for programs to think about. We're often asked, what's the cost of a behavior change intervention? And I think it's interesting to reflect on, is the intervention that you're introducing, are you trying to get people to adopt a new behavior, or are you trying to get them to maintain a behavior? If you were to go back and try to design an intervention, not to have people adopt a new behavior, but maybe the same population of health workers, if you wanted them to maintain the behavior, what sort of approach might you take?
I mean, I think one of the things here is talking about it as a behavior, and I wonder whether that's slightly misleading, because I don't know that when we frame it as a behavior, it's like we're saying, you know, you're doing, it's what you're doing, but I think people are just prescribing. It's just their practice, and their practice changes as norms change, as the environment changes, and so what we used to do, we don't do anymore, and that just changes, and then something else will come in, and so the effort that you have to go to change what the norm is, or what the expectations are of what you will do, and what patient expectations are, and what your expectations are of your colleagues and of yourself, and you know, within the medical profession or the clinical officer profession, that what it takes to change that professional expectation, I think, is really what this project demonstrates. And so then you don't then have to kind of be maintaining a behavior in the same way as a behavior like hand washing requires continuous maintenance. I need to continue to wash my hands. But when it comes to something like prescribing, you just change that, you change how many people you're expecting to give an antimalarial to, and then your expectations for that are changed until you have more information or something that changes that again, like you have an outbreak or something, and then you will change what you're doing. But I think, so that's where I think when we lump everything together under the umbrella of behavior, then we are lumping together different questions of different types of things that we're trying to change. And I think when we change what professional norms are, that's one thing. Changing something that you have to keep doing every day, like washing your hands, is a completely different thing.
Thank you. I think that's very helpful. We've got a question here from Bridget. Bridget, you're unmuted. Do you want to ask your question?
Oh, sure. I was just curious. Thank you for saying in particular the work that goes into creating these leaflets, that there was a lot of thought and study. But could you say more about when the patients received the leaflets? Was it when they came in for the fever, or was it something that was shared in the community in advance?
So we gave the leaflets to the health centres, and so they could do what they wanted with them. Mostly that just meant that they kept them in the clinic, in the office, and they were giving them to the patient when the patient came in and they needed to have a malaria test. They would use it to explain why the patient should have a malaria test. And they were also on the wall as poster versions in the clinics. We didn't directly give them out to community members. So these were kind of used as devices for the health worker to explain, to try and get over any conflict with patients.
Great, thank you.
I can see some more questions. Jessica Butts, what intensity of oversight or monitoring was needed during implementation to ensure participating health workers were adhering to the patient interventions, like the patient? So we didn't do any oversight to ask what they were doing. The only thing we did was we had people who were non-clinicians sitting outside 2 days a week on a random different days a week to do patient exit interviews. We didn't have any kind of oversight or ongoing intervention with the health workers in any of the arms beyond the intervention that was kind of the prescribed and described intervention. So we didn't ask them, we didn't sort of say you have to, we didn't give them feedback on their prescribing, whatever. They could do that themselves if they wanted to, but we didn't kind of continue to enforce or supervise them in any way, because we wanted to be slightly more programmatic. Angela Acosta, what might be useful in considering how to approach the issue of reducing both anti-malaria and antibiotic agents? How did you account for the stockouts? And good question. So in terms of the stockouts, we were fortunate we didn't have stockouts. We supported the provision of RDTs, and ACTs were in stock throughout the study. That is not always the case in other settings, and in some of our other studies, stockouts of ACTs really were a massive problem. So yeah, that is a really important thing to consider in some of the. We were fortunate in this study that we didn't have stockouts. What might be useful in considering this issue of both anti-malaria and antibiotic overuse? In my view, and a lot of my work at the moment is about antibiotic use as well. Fever case management in these kinds of settings requires a different type of care. At the moment, one can argue that what we call pharmaceuticalization of a care has occurred, whereby the provision of care is the provision of medicines, and actually healthcare has been stripped down to the provision of medicines, and that is articulated throughout our development programs, whereby we count development in terms of how many antibiotics have been sent over somewhere, or how many antimalarials have been sent over somewhere, or how many bed nets. And we count care in terms of how many things have been prescribed. And actually a lot of our algorithms are centered around the provision or not of a medicine. And I think we need to consider whether we can reorientate the provision of care to not just equate to the provision of a medicine. And that requires us a rethinking of how we train health workers and what we value, and how we think about how much time should be spent with patients. And I don't think that is specific to low, middle income countries who face exactly the same problem in the UK.
Claire, we combine two of the questions here. We've got a question from Precious in Nigeria about whether there's been any such study there. And also at the bottom, Susan's asking if we would expect these results to be generalizable to any other countries. So I guess from our audience's point of view, what can they take home to their own countries?
So we did do a similar study in Nigeria with a research group at Enugu University. And so I think the lead author was Obi Onwujekwe. And that project went through a similar rigorous design of intervention and randomized control trial. We included the drug shops as well in the analysis, in the intervention and analysis, and there we didn't use exactly the same intervention design. It was much more programmatic, and that's one of the scenarios in which massive issues of stocks, massive issues of the issues of stockouts was so difficult that I think it made it quite difficult to really analyse the data, which I think was an implication that somebody else was mentioning before, and also the drug shop vendors were really reluctant to use the diagnostic tests at all. So uptake itself was very low. So we didn't find a very big difference in that study. I would have to check back on the exact figures to tell you, but I would look at that study in terms of what the context was in Nigeria. I do think that we find things quite differently in different study settings, even if they're quite similar interventions. So I think it's different whether you're working in the government health workers or the mission health workers or private sector, in terms of whether people want to take up RDTs and want to use an RDT as an arbiter of whether somebody deserves a medicine or not. And if you're business orientated, you may well not want to do that, versus when you're being told and you're receptive to the authority of the biomedical profession, then we see quite a different story. So we see that playing out differently in different country contexts according to the degree of authority at which of the biomedicine as a profession has. And I think that also goes to whether, for example, when you compare between countries, who actually is registering and legitimizing a particular healthcare practice. In some countries, it's the Ministry of Mines or the Ministry of Business. In other countries, it's the Ministry of Health, and these or Ministry of Finance. And that means that there is a very different expectation from what those people, an accountability mechanism for those people who are prescribing. So I do think it's different per country.
Thanks, Claire. I think it's a good point that one of the goals of this activity is to make sure that there are take-home lessons, but at the same time, it can be very difficult to generalize across different countries. We've got a really great question here.
We have done a cross-country. We've done 2 cross-country analyses, so I'll put them into the chat box to show what we thought worked in terms of interventions that is generalizable across our countries. So we did do this in 8 different countries.
Excellent, thank you. We've got a really great question here from Foye. She wanted to know if the patients in the health worker, the HWP arm, do you think that there was more people tested in that arm as a result of kind of being primed as a result of the intervention?
Say that again.
She said, I think that's interesting that significantly more eligible patients were tested in the HWP arm, so the combined. Could this be because patients were primed and could demand a test before treatment?
It depends if those patients. So I don't know if the patients were seeing the poster and asking for it in those settings, or whether the health worker just felt more able to do the test because they had these leaflets and they were being. It was kind of a cue for them. But yeah, it's possible that it's the patient asking for it. I think it's more likely it's the clinician thinking, being prompted by the fact that they have these leaflets, that they would then do the test. But I also think it's interesting that they had fewer positives. So yeah, it's quite interesting further analysis that might need to be done.
Sure. Is there anything, Dr. Chandler, in that you learned in this study that maybe wasn't in the presentation today, but any take-homes that you really felt were particular?
Yeah, I think the biggest take-home was that designing these interventions is such an intensive process and takes so much longer than we think it's going to if you want to do it well. Even just thinking about the colours of the materials that you're using, you don't just make a guide for the trainer, you have to make something for the trainee to sit and work through. You have to kind of think about what the trainer's going to say. You have to train the trainer in a particular way so that they're not wagging their finger at people and telling them that they should or shouldn't be doing something. So there's just so many things that you have to think about, and you have to prescribe in order to test an intervention, to develop and test an intervention like this. Yeah, it was a lot more than we expected.
All right, thank you so much. Well, if there aren't any more questions in the chat box, maybe we'll just wrap things up. Just as a reminder to everyone, this discussion came out of what has an evidence database that has been created. We've got a number of tools to help you and your program advocate for using research to prove to donors and to your partners that social and behavior change communication are indeed effective, and show them the results of available research. A couple of our tools to do this. We've got a number of infographics, as you can see, both for ITN's service providers, as we've talked about today, as well as malaria case management. These are sort of the highest level, simplest descriptions of different activities that have been successful. There are links and citations underneath each of them. These are available on the same website as the database itself. Another way of looking at this research is at fact sheets. We've taken a number of studies and evaluated them in two ways. One, based on the rigor of the study itself. The second way of looking at it would be to ask and analyze what sort of social and behavior change best practices were used. So for each of these, you'll find different colored dots that indicate both the rigor of the study and analysis, as well as best practices that were implemented. And with that, we'd like to thank you for participating today. If you have any questions, comments, if you want to follow up at all, you can see Claire's contact as well as my own on the screen. Please stick around. There's about a 30-second survey we'd love if you would reply to before leaving. Thanks, everyone.